Do you swear affirm the following testimony will be the truth, nothing but the truth?
Yes.
Dr. Branch, would you start by telling the jury your name?
Thomas Paul Branch, MD.
And where are we right now?
We're at 1014 Sycamore Drive, Decatur, Georgia.
And is this your office?
This is my Decatur office.
What date is it? Do you know?
It is March 22nd,
Thank you.
2018.
I see you have your coat on, some scrubs. Have you been treating patients today?
Yes.
Where do you currently practice medicine?
Here in Decatur and up at Northside office
Where did you go to undergrad?
at Duke University.
And did you attend medical school?
Yes.
Where at?
Emory University.
Did you have a residency?
Residency, internship in the Emory system and the residency at the University of Minnesota.
Did you do post-grad work in Minnesota?
And I also took a year during my residency to complete coursework towards a master's degree in biomechanical engineering.
And did you have a fellowship?
Fellowship in sports medicine at the University of Florida.
Are you licensed to practice medicine in Georgia?
Yes.
Are you board certified?
Yes.
How many times?
I've been recertified now twice.
Do you belong to any professional organizations?
Multiple.
For example, are you a member of the American Academy of Orthopedic Surgeons?
Yes.
Are you a member of the Georgia and the Atlanta Orthopedic Associations?
I believe for certainly the Georgia Orthopedic, and I think I'm current with the Atlanta, but I'm not 100% sure.
Have you ever been recognized as by Atlanta Magazine as a top doctor?
Yes.
Do you have any hospital privileges?
DeKalb Medical Center, Northside Hospital, and North Lake Surgery Center.
What type of surgeries do you perform on people?
I specialize in musculoskeletal medicine. I do and have done almost every part of the body.
And would you call yourself an orthopedic surgeon?
An orthopedic surgeon, we specialize in joints and bones, soft tissues, the musculoskeletal system, including the spine.
Have you ever been the head of surgery at North Lake Surgery Center?
I've been the chief of surgery at North Lake Hospital, which is now currently the Emory Orthopedic and Spine Center.
I'm going to hand you what's been marked as Plaintiff's Exhibit 1. Can you tell me what Plaintiff's Exhibit 1 is?
It's my curriculum vitae.
Is that a fair and accurate copy of all your accomplishments?
Yes, although we could get an updated version if it's necessary.
I'll tell you, your office printed that out today for us, so I would trust that is updated.
Okay.
We move Plaintiff's Exhibit 1 into evidence.
No objection. We'll stipulate the doctor's an expert in his field.
All right, we'd like to tender Dr. Branch then as an expert in orthopedics and orthopedic surgery. Any objection?
No, so we'll stipulate he's an expert in his field.
Okay. Doctor, I want to talk to you about a client of mine, a patient of yours, Gregory Summerhill. Do you know Mr. Summerhill?
Yes.
Are you familiar with Mr. Summerhill's injuries and the treatment that he received?
Yes.
Will all of the opinions that you give today regarding Greg's injuries and treatment be to a reasonable degree of medical certainty?
Yes.
What kind of injury did you conclude that Greg had?
I concluded, based upon the history, physical examination, MRI findings, that he had a peripheral horizontal cleavage tear of the posterior horn of the medial meniscus, grade 2.
Did you treat Greg for that injury?
Yes.
Did that treatment involve a surgery or multiple surgeries?
It involved a surgery that was performed on September 16, 2015. At that time, we did a diagnostic arthroscopy, which is to look inside the knee with a fiber optic system that projects what's inside the knee onto a TV screen, and clean the knee up of any scar tissue, and then looked at the meniscus. We found again that he had confirmed our concern that he had a medial meniscal tear, and that the tear was grade 2. In other words, it was inside the meniscal leaf, but didn't extend to the surface.
Doctor, the question before the break was, did you perform a second surgery on Greg on April 19th, 2017?
Yes.
And what was that surgery?
That was the first surgery was to inject blood into the defect of the meniscus in an attempt to get it to heal. And the second surgery was to take out the rest of the meniscus because it just didn't heal over a period of time. Didn't heal, and by the time we got a second MRI scan, the MRI scan suggested that the tear had now extended to the surface of the meniscus. At that point, it typically has to be removed.
Doctor, was the treatment that you provided Greg reasonable and necessary?
Yes.
Were the bills that Greg incurred as a result of the treatment also reasonable and necessary?
Yes.
All right, you've told us some of the highlights. I want to walk you through Greg's course of treatment.
Okay.
Doctor, when did Greg first come to see you?
5/18/2015.
Doctor, in May of 2015, why did Mr. Summerhill come to you?
He came to me on 5/18/2015 with the complaints of continued right knee pain, which he associated with an incident in which a dog bit him on the right knee, and that during the attack he attempted to twist and pull his knee away from the dog.
Before Mr. Summerhill came to see you, had he had an MRI done?
Yes.
And did you review that MRI in May of 2015?
Yes.
What did you find?
We found a peripheral horizontal cleavage tear of the posterior horn of the medial meniscus. That tear was a intrasubstance tear. It's a grade 2 tear in the middle.
Let me hand you what we've marked as Plans Exhibit 2. This is a diagram called the knee. Have you ever seen this diagram before?
Yes.
You provided it to us, so I'm sure that you have.
Yes.
Would you hold that up for the jury?
Yes.
And let us zoom in on it for 1 second.
Particularly this one.
All right, you go ahead, doctor. If you could explain to us.
This happens to be the lateral side of the knee, but it's okay because it's going to give us an illustration of the medial side also conceptually. What you see is this little triangle right here, and that triangle is a meniscus. That meniscus is represented from the top, looking from the top here. On the medial side, it's a C-shaped, and then on the lateral side, it's a kind of a O-shaped, almost O-shaped meniscus. Meniscus is like a washer in the faucet.
Is that the blue color we see, doctor?
Blue color here.
Okay.
The blue color also coats the end of the bone. That's articular cartilage. That's the stuff on the surface of the bone. So what he has is a tear in the middle. Now, it's going to be difficult for you to see this, so I'm going to draw the meniscus out and expand it, and then I'm going to put a line in the center of it where the tear was.
All right, let us zoom in for 1 second so the jury can see it. All right, so what you've just drew, is that a representation of the meniscus, which is in blue in the diagram?
Yes, and this is now a white kind of triangle, and the center part of it is torn. It's sort of like an unstable Oreo cookie, if you will.
All right, and what part of the Oreo cookie would the meniscus be?
Well, the meniscus has got a cookie on the outside top, a cookie on the bottom, and in between is the filling, and the filling no longer keeps the two cookies together. They move separately when you have a grade 2 tear of the medial meniscus.
Does a grade 2 tear like the one you just described, is it typically painful for patients?
It is painful for patients. Interestingly, it can be identified both as non-painful. There's some patients that you can have a grade 2 tear. Typically, they're young. You can see changes in the MRI scan in a under 20 group that look exactly like this, but they're normal. Over 40, when you get into those older age groups, those are where those are unstable meniscal tears that are emerging. In other words, they're starting as a meniscal tear. The classic meniscal tear is the one that goes through the cookie on the top or through the cookie in the bottom.
Because Greg had this injury, did you write him out of work?
Yes.
Did you recommend a course of treatment for Greg in the future?
Yes, I recommended that he have a surgery and an evaluation of the meniscus under anesthesia through the arthroscopy, which is the fiber optic lens into the knee, with the potential of either resecting the meniscus or repairing the meniscus.
In September of 2015, did Greg have to go through any testing to make sure that he actually could have the surgery?
Yes.
And what was that testing?
I believe, give me 1 second to be 100% sure, he had cardiac testing. That testing was done on September 1st, 2015. And it was to make sure that his heart was okay to have surgery.
Although it's a surgery on his knee that he was going to have, why were you worried about his heart?
Well, when you put somebody under anesthesia, you have to control their blood pressure and all their major functions while they're asleep to make sure that they're okay. If a heart is even potentially compromised in any way, you need to know that to be particularly careful when you put someone to sleep.
Did you have a preoperative visit with Greg in September?
Yes.
What do you do at a preoperative visit?
Well, I'm making sure that all the paperwork is organized and done, and we make sure that he gets the appropriate before surgery cleaning processes in place to make sure they minimize the effects of potential infection or other complications.
Before the surgery, do you also tell all of your patients, including Greg, about the dangers and the risks of the surgery?
Right. They have to fill out an operative consent for the surgery.
What kind of risks are there in a surgery like the one Greg was about to have?
Well, the anesthesia risks, and that's a separate consent, but there's a risk of infection. There's a risk of failure of the surgery itself. There's a risk of, those are probably, and risk of blood clots.
And what are the separate risks for going under anesthesia?
Those are related to the drugs given for anesthesia and can be best delineated by the anesthesiologist.
On September 16, 2015, did Greg have the surgery you recommended?
Greg did have the surgery we recommended. When we got in, again, the meniscus had an area that, again, confirmed our instability of the meniscus, the intrameniscal instability, but it did not go to the upper or the lower leaf. I know it's that's the perfect environment, in my opinion, to see if we can get it to heal by taking the patient's own blood and injecting it into the meniscus.
Can you explain how you take someone's blood and inject it into their meniscus?
Yeah, you basically take the blood, have the anesthesiologist take the blood from the arm that's not involved with the IV, typically, and then you take that blood and pass it off to the back table, and then I take a long needle that's this long, and I carefully put it through the skin into the meniscus, and typically along the edge or the border of the meniscus to try to put the blood in along that area to form like an eschar, to get, just like you'd have a eschar would be like a scab on your skin. We'd want the same effect to occur down into the meniscus itself.
To use your Oreo example, is it like if you're drinking milk with your Oreo, you actually inject the milk into the white part of the Oreo?
Even more interesting, you would inject more cream. You inject more filling into that area.
And that way you'd have a better Oreo.
Try to glue those two cookies back together.
I guess my mind was on eating, your mind is on making the Oreo stable. That makes sense. Where was the surgery performed?
The surgery was performed at the North Lake Surgery Center.
Was this an outpatient or an inpatient procedure?
Outpatient surgery.
So was Greg able to go home that same day?
Yes.
Did Greg tolerate the procedure, meaning did he go through the procedure safely and effectively?
Yes.
Did you have a follow-up visit with Greg?
Had followed up on September 24th, 2015.
And how was he doing?
And, he felt that it was better than before surgery. He was walking a little bit with a limp. He still has some mild pain. However, he was taking a narcotic at the time.
Did Greg have sutures from the stitching that needed to be removed?
Sutures were removed on that day.
And why did you prescribe him a narcotic?
Well, because it potentially could hurt
For pain.
for pain relief.
Did he have a follow-up visit 4 days later on September 28th, 2015? Let me try this question, doctor. When was Greg's next visit with you?
Well, he could have been on September 28th. I just don't have the record in front of me.
That's okay.
I have to go get it. Did you have that record?
I don't. What I was going to ask, though, was how was Greg's recovery over the next couple weeks or months? How would you
I
characterize
saw him on 10/15/2015. That he was improving his range of motion. His swelling was improved, and he was slowly. He has occasional sharp pain in his popliteal area, but that. He's still having, at that time, as a 10/15, he was still emotionally involved with this whole process.
Did you see Greg towards the end of 2015, in November or December?
Saw him on November 24th, 2015, and he did have an opportunity to see a psychologist, which he felt was helpful, and that he's slowly increasing his activity level after surgery, and that he was able to walk 1 mile without complaint, and he continued to improve.
Now, in early 2016, did Greg come to you with any persistent problems, meaning regular problems about pain or anything like that?
When I saw him January 12th, 2016, he felt that he was continuing to improve. He was not going to physical therapy. He was not working at the time. He, at this point in time, that he was nearing the finish of his, he's nearly fully healed with respect to his work injury. And that in order to kind of finish everything, to get him back to work, we were thinking about 1 more month of therapy.
At some point, did you recommend, and I might be pronouncing this wrong, but hyaluronic acid injections?
As of As of 2/5/2016, he continued to improve, but felt like his knee had reached a kind of a stable spot that still had intermittent weight-bearing pain. On I appreciate. Oh yes, on 5/2/2016, we felt that at this point he might try a lubricant injection in his knee.
And can you tell us what this injection consists of?
It consists of, it's a hyaluronic acid, which is a natural component of the lubrication system within the knee, and it's meant to augment this.
I have a syringe and I've got a needle. Are you familiar with these two things?
Yeah, I mean, this is the stuff. I mean, when you inject it in the knee, if you were to actually feel it, it does feel a little bit like a lubricant. It's slippery. It's more substantial than KY jelly, for instance. But it's slippery like that. It's not an oil. It's a natural protein that's in the body, and you use a needle to put it in there.
Would you hold that needle up for us?
Yeah, I mean, it just attaches like this. I mean, and you have to kind of, it's best if you use a larger bore needle because, which is a little bit thicker needle, because it's so thick to get it in there. You want to be able to get it in. A thin needle, it just takes so long to get it in that it just is not worth it. You either leave it in a long time and then you're putting that needle in, or you have a nice thicker bore that just can slide right in.
And did Greg have 3 of those needle injections?
Yes. He had one on 5/2/16, on 5/9/2016, and on 5/20, I believe, yes, 5/20/2016.
So he has these 3 needle injections in May of 2016 at 3 different visits. Does he come back to you in June and report anything?
Yeah, I mean, he feels that the injections made him better.
And on June 17th, 2016, what did he report to you about pain?
His pain was now 2 out of 10 compared to 8 out of 10 where it was originally.
Doctor, on June 17th, 2016, did Greg report any sort of pain to you?
Well, he does state that his right knee did have some sharp lateral right knee pain that radiates down to his right ankle. And that he feels like his pain was worse and sharper than ever, although that his current pain was 2 out of 10. Sitting and walking make his pain worse, and his prescription were helping his pain. He is wearing a brace at the time.
Did you recommend any kind of imaging, testing for Greg?
We thought that it might be reasonable to go ahead with that history to repeat his MRI scan.
The next month, in July of 2016, did Greg have the MRI?
Yes.
And were you able to review that on July 22nd, 2016?
Yes.
What did you find through the MRI?
What we found at that time is that, the tear, in fact, had not healed. In other words, the Oreo cookie had remained unstable, and now it had cracked one of the cookies and is extended to the surface.
Now, did you read this MRI yourself?
Yes.
Are you trained to do so?
Yes.
How many MRIs would you say that you read each year?
I mean, four or 5 a day.
And do you want to read MRIs yourself before you perform a surgery on a patient?
Yes.
Is that important to you?
Yes.
So after reading Greg's MRI, what did you decide should be done?
At that point, we decided that the tear had not healed and that the best thing to do is to go ahead and remove it.
In August of 2016, did Greg come back to you?
In August of 2016, he did.
And did he report, or what did he report regarding his pain, if anything?
Pain has continued, pain is worse, and now he's got some irritation from the anti-inflammatory agents that he's taking in his stomach in order to try to manage this pain, and his knee is just worse.
Now, how did you conclude in this August 16th visit whether Greg's first injury or first tear that you performed a repair on somehow was related to this second surgery or the need for it?
Well, I mean, the obvious answer is that you really try to preserve the meniscus. The meniscus is like a washer in a faucet. That meniscus protects the bony structures and the articular cartilage. The articular cartilage is the stuff when you snap open a chicken leg. It's that glistening white surface that coats the bone. That needs to be preserved. And the meniscus itself takes a round bone and distributes the force across that round bone to the flat bone of the tibia. You can kind of see it here. Takes the round bone, it distributes the force more evenly across to the bottom bone. And you remove that meniscus, it creates a higher concentration of pressure. If the meniscus is flat, just like a flat tire, right, it won't function as well as a normal meniscus.
In your notes from that August 16, 2016 visit, did you express an opinion about whether the need for this second surgery was related to Greg's injury in 2014.
So let me continue. I appreciate that clarification. So when we do the injection of blood, we're attempting to get the 2 layers to heal, but it fails about 20% of the time. I mean, the success rate's not 100%. So we want that to work, but if it doesn't work, then we watch people very carefully, because the alternative is to take it out in a flap tear. When you've got that horizontal cleavage tear that's not really gone to the surface yet, the alternative is to take it out, and it's really, no one wants to take it out unless it's all the way through the surfaces. Well, it just so happens on the second time around, it went through the surface. So the fact that he got better and then suddenly it failed suggests that meniscus never fully healed.
Did you end up performing this second surgery on Greg?
Yes.
Did you perform in April of 2017?
Yes.
And can you describe for the jury what this surgery entailed?
Yes. We look inside the knee with what we call an arthroscope, and which is a little tube, and we make 2 incisions, and we literally go in, and I'm going to show you this here, and we trim out the meniscus. We take out the area that I've sort of hatched. That area was damaged to the point where it needed to be removed.
And would you point with your pen
Yes.
or your finger was great where you just drew?
Yes, right there. All of that meniscus now is taken out.
This surgery that Greg had, where was it done?
It was done at the North Lake Surgery Center.
And was this an outpatient or an inpatient surgery?
It was an outpatient surgery.
Did Greg have any complications during this surgery?
No.
Was it the same deal where before he had the surgery you had to explain to him the risks and the dangers?
Yes.
And did Greg willingly agree to go forward with the surgery?
Yes, he did.
Did he have any post-follow-up or post-surgery follow-up visits?
Yes, I mean, we're continuing to follow him in clinic. We have a visit as of (4/24/2017).
Dr. Branch, let's jump ahead to actually May 19th, 2017. Let's tell the jury about the good news for Greg. Can you tell the jury what he reported to you about his pain in May of 2017?
That he's feeling a lot better after surgery.
Great. Doctor, now that we're kind of up to the present, I want to ask you about Greg's future. Is he at risk for any future treatment or surgeries even?
Yes, I mean, when you take out the meniscus and all your pressure, or you damage a meniscus and all your pressure goes in one spot, it wears out. I mean, we've known that since 1949. Fairbanks wrote a wonderful paper that said there's a high incidence of going on to significant medial arthritis, or where you wear out the articular cartilage, which is on the surface of the bone, as opposed to the meniscal cartilage, which is that washer. So you lose the washer, then the next step is to lose the articular cartilage, and once you lose that, then you need a metal and a plastic knee, which is a total knee arthroplasty.
I'm going to hand you what we've marked as plan Exhibit 3, and can you tell the jury what that is?
That is a note that's a surgical estimate of what it would cost to get a total knee arthroplasty.
Did you prepare this?
Yes.
Is it fair and accurate estimate of the future total knee replacement?
Yes.
Plaintiff now enters Plaintiff's Exhibit 3 into evidence. All right, doctor, the last few questions I have for you are just about Greg. Did he comply with your instructions while you were treating him? Did you believe that he wanted to get better?
Yes.
Was he a good patient?
Yes.
As far as you know, did he always tell you the truth?
Yes.
Well, thank you very much, doctor, for your time. I have no further questions.